welcome everyone to Pharmacy Grand Rounds for February. I'm Heather Naylor, the Pharmacy Research and Education Coordinator. So I see we have 14 people signed on and a full house in St. John's. We'll get started. I'm pleased to introduce Carrie Ann Dorn, who's a pharmacy technician from Alberta. She delivered this talk at the CAPT conference that was in St. Andrews last May. We had really positive feedback from our staff that attended. So Carrie Ann has graciously agreed to give the talk again to our staff so you guys can learn from her. So I'll hand it over to you, Carrie Ann, if you'd like to tell us a bit more about yourself and go into your presentation.
Sure, sounds good. Can you hear me?
Yes, we can hear you great.
Perfect. Okay, so I'll tell you a little bit about myself. I'm a pharmacy technician in Alberta, and I currently work in a fairly niche practice of what we call outreach pharmacy. Basically, we work with the homeless who are palliative, homeless who suffer from mental health and addictions, patients who are recovering from drug abuse and addictions, mental health, women's issues, transgender teens on the street. I currently work at a clinic that has 3 outreach buses, but before that I worked at Luke's, and my talk today is about that. So this is about my time with Luke's. So good morning. My name's Carrie Ann, and I've been working in pharmacy for almost 9 years. Firstly, I want to take a moment to thank Horizon Health for offering me this opportunity to talk today. The subject matter that I'm sharing today is not a new concept, and it's not knowledge that solely belongs to me. I've been given permission to use these stories from the individuals, and in a lot of the cases, I've changed the names and a lot of the details to protect their safety. My goal today is to bring you to the front lines of what the media has been aggressively calling an opioid crisis, to shine some light on why we need to drop that nomenclature. I want to give you examples from my personal working experience and invite you to learn that despite pharmacy technicians being treated like they're lower level in the healthcare system, we can be of value in the day-to-day lives of those struggling with opioid use disorder. I want to lift us all up and remind each of us that our role is important, and in this case, helps to fill in a gap and be a team member for the national healthcare system. The smallest of tasks, carefully performed, are a stepping stone to advancements. Woo, my slides, sorry. So I always have to say a presenter disclosure. No one has helped me in any way. No one's financing me, no one's backing me. I do this for advocacy and advocacy alone. So again, I have no commercial support. So what I plan to go over is opioid use disorder, the role of the pharmacy technician using best practice medical history, and then the 3 case studies that demonstrate the use of empathy and breaking down stigmas. Understanding compassionate care while still managing to maintain a scope of practice is difficult. When working with individuals who are already stigmatized, we need to recognize that it was a large step just to come forward and share their story with us. We need to recognize that their world is one of risks and that their personal stories that they entrust to us hold a massive value to them. At the same time, we have to maintain a scope of practice and keep within this. It might mean telling someone who has trusted you and only you with a health-related detail that you are obligated to tell another health practitioner. Our national government and pharmacy colleges continue to change standards, practice, programs, and policy. Every week, as a practitioner of healthcare, we see headlines and newsletters, updates and websites, ever-changing strategies, new fentanyl patch management, changes to Suboxone guidelines, the expectations of prescribers to reduce quantities, the role of harm reduction, stickers that go on bottles, pamphlets that accompany narcotic scripts, teaching materials on how to use naloxone, and every day a new CE and a new standard of practice are added, all geared towards this goal of harm reduction. Every day, week, month, new changes are made, and yet, by the time I present this here, the language I'm using will always be out of date. I started to work on this presentation in September 2 years ago, and I already feel like a lot of the ideas I'm going to share today are changed, because it's a fast-changing environment. But I want to take you away from a lot of the formal literature and into the stories of those who live this every day. So if every day the rules are changing, and yet every day you're the same patient, it becomes this balance, this ethical gray area with our daily witness patient. I want to maintain respect for them without becoming offensive to them, but the rule changes. The rule changes. So what was suddenly appropriate one day isn't appropriate the next. All the while, they're trying to follow every single rule to stay in their program. So from their point of view, it comes across as all their hard effort just isn't enough. I've seen patients feel defeated and even more marginalized by changing the rules all the time. So I want to remind you that those with opioid use disorder are still at face value a person. Okay, so very quickly, what OUD is, and I feel like this is now very much out of date. I want to let you know that where we get most of our information is from the DMS-5. It has 11 points, and then in my province, the Alberta College of Pharmacy, we have guides for methadone and Suboxone, and they want us to use DMS-5, TR, and then only the 9 key points. So those are the following. A maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by 3 or more of the following occurring at any time in a 12-month period. So this is their definition for what counts as opioid use. Tolerance is defined by either of the following: a need to markedly increase the amounts of substance to achieve intoxication and desired effect, markedly diminished effect with continued use of the same amount of substance, withdrawal as manifested by either of the following: characteristic withdrawal syndrome as set from a specific substance, or using substance closely related to take to relieve the same or avoid withdrawal symptoms. The substance is often taken in large amounts and over a long period than it was intended. There is a persistent desire or unsuccessful efforts to cut down and control substance use. A great deal of time is spent in activities to obtain it, so multi-doctoring, driving long distances, uses of other substances like chain smoking and recovering from its effects. Social, occupational, or recreational activities are given up or reduced because of substance use. And the substance use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused and exacerbated by the substance itself, i.e., if you know you have an ulcer but continue to drink. So I think that there is a newer definition out there, and it's one that I agree with. So to me, I think OUD definitions should no longer make a distinction between substance abuse and substance dependence. Therefore, it should include individuals who have been given opioids for legitimate medical reasons and have developed tolerance over time, as well as those who use opioids for recreation. So it's dependency and pain and withdrawal for both parties. So a little bit about my working environment last year. I worked at Luke's Drug Mart, which has been open since 1951 and is a family-owned and operated store. It's currently in the 3rd generation, and it's this hip little coffee shop in the front where we sell records and ice cream and all these things from New York, and Jack White comes and visits every time he goes to Calgary. But it's also located in Bridgeland, right across from the drop-in center, which is one of the largest shelters in Canada. So it's a cute hip shop in the front and then the pharmacy in the back. It's a hop, skip, and a jump away from the drop-in center. The drop-in center is a temporary shelter for more than 1,000 people every night for families and individuals in need. Our store works closely with the center to help them meet their needs, and some days we work beyond medications. But it's not just the drop-in center. I work with patients from the Calgary Women's Emergency Center, the Mustard Seed, Center of Hope, Salvation Army, Camp Team, Alpha House, YWCA, Maple House, and The Source, just to name a few of the organizations. We're also supported by many of the doctors at ODP, which is the Opioid Dependency Program, CUPS, and the ALEX. Our pharmacy team values an idea that harm reduction means more than opioid treatment. It can include all medications and devices that would aid in medical treatment to prevent the need for a hospital visit, i.e., replacing a COPD-needed puffer that may have been lost or stolen, as opposed to a patient who has run out of government-insured funding to pay for the device and subsequently needing to stay in hospital, which would be more. Sometimes it means replacing food, and sometimes it means finding shelter. So I used to work at a compounding pharmacy, and it was geared towards the upper class. It was designer compounds, and that was what I knew for 6 years. And then I decided to take a challenging leap of faith and join a small-scale, family-owned operation, and I had no idea what it was going to be. So I went from working with patients who could afford designer medications to suddenly, out of nowhere and without expectation or understanding, working with patients who have very little possessions and keep everything they own in a single bag or on their shelf or in a shopping cart. And that would now include their medications. So when you have diabetes, for example, and you haven't got a place to keep your blood glucose or your insulin so that you know that it's the correct temperatures and being stored correctly, it was heartbreaking for me to see this. So I started making changes in my practice. And so that started to include doing diabetes care and having a machine and all the supplies for each patient and keeping their insulin. But it wasn't always going over well with the rest of the neighborhood. So as an example, patrons of the front end coffee shop complained about a drunk man stumbling outside our store. But the truth is, this man is a type 1 diabetic, known to our pharmacy. He lived in an assisted living facility, and his Alberta disability payments, known as AISH, do not stretch as far as it should towards the end of the month. And he doesn't eat enough or have enough test strips daily to dose his insulin correctly. So this is a patient that was stigmatized by the term drunk and homeless. I regularly assist patients. This was now becoming a part of my job. But I was also offering orange juice, chocolate, and dextrose tabs for anyone who encountered diabetic lows. But beyond that, I was becoming a safe space in the community, a haven, a place to reach for medical assistance. And that included sometimes calling an ambulance for your friend who's too scared or passed out and needs assistance. Some of our patients just don't have phones and don't even stay in shelters. It would have taken a lot of courage for them to come to us for help. And often they will even ask, do you absolutely need to call an ambulance or a police officer? And this was because in their world, emergency services have not always been the safest choice, have not always provided care. And that's why we were important to the neighborhood. Our patients from the drop-in constantly tell us, I see you more than I see my doctor. I trust you more than I trust my doctor. Because of you, I'm alive. If it wasn't for Luke's, my condition would get much worse. None of these statements will be found amongst the formal pharmacy literature. No one treats pharmacy as a front line in medical services. However, we are, especially with our opioid use disorder patients. We see them every day for their daily witnessed dose. We know every detail of their life. We celebrate their successes. We monitor their struggles. We put a name and a face to a person who might only be a statistic in a crisis. And we see them every single day. Rain, snow, Christmas, Easter, sunshine, ups, downs. And every day they bring a new challenge to us. Someone living in their car, someone going out without food, someone who knows someone who did something illegal. Humans naturally have ups and downs, and it's imperative to remember as a technician, my biggest role and my most important role in these situations was best passable medical history. It's our role to keep patient medication history and records, listening to the patient's stories, but collaborating with another healthcare provider or a second source. So the biggest thing that we're taught is to ensure that a best practice medical history is completed using at least 2 sources. Electronic health records are at once a source of medical information, but are not an ultimate one. Patients themselves or their caregivers are the best source to determine how they're actually taking their medications at home. How the medication is prescribed is not always how it's being taken. And complete medication information is not always shared among care providers. Or, best practice medical history can be understood as a systemic process of interviewing the patient or a family member and a review of one other resource. So in Alberta, we have Netcare and doctor sort of emails. So, for instance, Netcare, and this is a story. For instance, Netcare has shown that the patient has had 2 visits to ER for hypertension. The doctor notes that they're being compliant. I prove that they are being compliant by checking their blister pack history. The doctor has tried 3 different meds. So I sit down and I have a heart-to-heart conversation and I ask them, are you taking anything else that we don't know about? Vitamin supplements? Medications? How about recreational drugs that we currently don't know about? So here they have this high blood pressure and no idea why. But suddenly he goes, oh yeah, I've been smoking crack with my roommate. But not every day, just socially. Do you think that's causing my blood pressure issue, Carrie Ann? I've never told my doctor that I do crack. So that's an example where I have to now bring it to my pharmacist's attention and where I have to now get in touch with the doctor, but at the same time leave the autonomy of the patient to decide if they tell their doctor. So while I could robotically practice this with a paper form or an outline or a policy, I don't anymore. Because the forms were impersonal and slightly insulting at times, I would take this run-of-the-mill form that almost all the pharmacies out here in Alberta have, and I'd sit down with these patients and I'd ask them the questions on the form, and I was always met with hostility and mistrust. Like, it's none of your business. Why are you asking me this? You know this. Don't ask me these questions. I don't want to answer them today. So I had to change my strategy. When I work with these patients, I already know they're living risky lives and in a vulnerable situation. So it was kind of outrageous of me to try and stuff these people into check boxes and squares and formulaic questions. My strategy became simple. Change it. Change it. If a methadone, Suboxone, or Acadian record began to show gaps or issues, I would take the time to hang out with that person. Just hang out. Have a coffee. Have a cookie. Have some ice cream. Talk to them like a friend. And just listen. I have 3 stories to share today, and I will give you a trigger warning. Some of them are a little bit sad. One, to demonstrate how I do this practice and let people tell their own stories. So one will be a palliative patient who was homeless. One will be a man who was incarcerated and after coming out of prison struggled with stigma. And the last will be a victim of human trafficking. Okay. Gonna take a little breather, sorry. So the first one is SF, and this one's hard for me to tell without crying. So, SF has given me permission to share his story with the world. He wants me to shout it from rooftops and tell anyone who will listen, because his story matters. And he doesn't want to be forgotten. He wants to be remembered, and he wants people to think about this. SF was a homeless man who was palliative. Currently in the city of Calgary, we do not have palliative shelter or hospice space, and this always comes with a price. Those who are palliative and living between shelters have had to learn to live within their system. Each shelter has a allotted number of sick days that can be used for you to stay indoors. Once you've reached that limit, though, you have to switch shelters to gain new sick days and more time indoors. So, for example, you might get 16 days at the drop-in, not consecutively. You might get 8 days at Alpha House, and you might get 7 at the Mustard Seed. So you'll constantly move around and become transient between these places. In Calgary, we have this amazing team of 1 doctor and 1 nurse. Yes, it's a team of only 2, and they're called the camp team. They get in their car and they drive around and they find their palliative patients on the streets. They call the shelters, they look for them. They use the pharmacy, so in the case for me, they would use me as a staff member at the pharmacy as a communication tool. Because often these patients don't have phones and we didn't always know where they were, but they could always come to our pharmacy. If you had met SF before his diagnosis, you would have stigmatized him as an addict. Heck, he tells it like that. In his own words, he was a homeless, good-for-nothing, drug-dependent mess. But it wasn't always like that. His transition from normal, everyday Joe to a homeless started harmlessly. It started as back pain or an ache he just couldn't figure out. The pain had an innocent beginning, so he started with over-the-counter pain medication, and it would eventually grow into uncontrolled pain management that over time manifested into a dark dependence of street drugs, one that cost him his job, his friends, and his family. And now his drug-seeking behaviors had doctors questioning if his pain was real. After an attempted suicide, where he knocked himself unconscious, he was taken to the hospital. When he woke up, he was in a room with 5 specialists from oncology. He had been diagnosed with cancer that had spread and taken over 60 to 70% of his body, and it was now beyond response to treatment. When SF walked into my pharmacy 3 years ago, he had the biggest smile on his face and a triplicate prescription in hand. And I can easily say I've never seen someone so joyed to have received a cancer diagnosis. For him, he felt believed, and for the first time ever was given clean drugs and treatment to manage his pain. So the camp team had our pharmacy as his connection spot. So that meant if they needed any information about appointments, treatment changes, or check-ins, they would relay the messages with us. When SF's pain is in check, he's the sweetest person ever. And he'd be so excited just to talk and have a positive, life-changing, altering conversation with you. Because no matter how little we are given in life, we can still be thankful just to be a part of life. On the flip side, when his pain was not being managed, he was angry and aggressive and lashed out, had fights with EMS. It was not good. When things weren't going well, to me, that was time to hang out. So we would sit and have cookies, coffee, ice cream. I'd let him tell me how life is going, but I'm sure to make all these mental notes, how often he is taking medication, how much food and water he is taking in. You can imagine that if he's staying in a shelter, the food intake is not consistent or designed for someone with an ostomy bag. He will tell me that he is taking more of his required medications, the way he's feeling when he does that, and why he does that. Then he should, and he knows he shouldn't be. And he'll tell me things like, I don't think my fentanyl patch is working. So these are all the notes I keep. I keep them in my mind, because I'm going to refill out those forms. But I let him tell it in his own words, and I'll let him share his tales. Everything he says could be a part of the best practice medical history. The fact that his speech is slow and he forgets words demonstrates and confirms the notes from the camp team about the progression of cancer and the changes to his brain functions, and it confirms this. He hates the taste of all food. He's lost this. He might be going through food aversion from nausea, or he may have actually lost taste, and I'll make a note of that. These notes that I make will then be given to the camp team and the pharmacist, who can make adjustments. Meanwhile, I have an amazing and heartbreaking discussion of what it means to mourn yourself, and a spiritual and honest discussion about what it might mean to decide to choose MAID, medical assistance in dying. Sorry, I'm not going to cry. The unfortunate aspect of medical assistance in dying at the time that he was going through this is that the date that he picked could come and he may not be ready. So his first date did come around. And when it came, he still felt very energetic and full of life. He thought when the date was going to come around, he would be beyond his faculties and no longer able-bodied. So it scared him, and he decided not to do it. And with the help of the camp team and the pharmacy and the pharmacists that I work with, we set up a date for radiation, not for treatment, but for pain management. Ultimately, this treatment gave him 1 more year before the pain became too much to live with. He never wanted to let his pain make him someone's burden. Living in shelters and walking the streets every day during the day meant the following. Regular, everyday people, either never saw you, as if they look right through you, or they would look at him and judge him as a burden to their tax system. And he didn't want that. He doesn't deserve that. He didn't want to be a burden. So, on January 28th, 2019, SF passed away as a result of receiving MAID. A few days before, he came to the pharmacy and he gave me the biggest hug and a formal goodbye. And he told me that it would no longer mean being in pain, that the pain would be gone and it would be a final rest. Sorry, I'm going to take a moment. Okay, that one's a hard one for me. But we'll start to get a little happier. So next we'll talk about another patient, GW. So, GW was originally living in a halfway house, and after having been incarcerated for a number of years, had rejoined society, but not very well. Like, it wasn't going well. He had been coming to my pharmacy every Friday for several years before I even joined. And every Friday he was to get an allotted amount of medication, a 7-day restriction. He was getting gabapentin, codeine, and hydromorphone, all with this 7-day restriction. He seemed to be constantly caught in a world of irritability and pain. He was very aggressive every time he came in, would kind of argue with the pharmacist. And so finally one day, the pharmacist and I talked, and he's like, maybe you should sit down and have like a best practice medical history, see what's actually going on, see what we can do for him. So I did. I sat down with him, and he told me he was suffering from a spinal issue that he couldn't explain in words, that he'd seen many doctors, but was struggling to get a doctor to accept him full time. He hated his pain. He hated having to use pain meds. He wanted to use less. He didn't want to need them. These are words that are familiar to me because most of my patients who suffer from chronic pain, who are started on opioid management, become caught up in a repetitive cycle where they're living between physical pain and withdrawal symptoms. GW would explain it as, I don't know the difference between the pain from my injury and the pain from withdrawal from my medication. I don't know the difference anymore. I put him on our patients to monitor list and made sure that the pharmacist gave him time to review how he was using his medication, and that he would need to review each week with the pharmacist on medication use. Why would I do this? Because best practices teach us to be vigilant and report signs of early fills. The reality, though, pain management for people changes day to day. We began to keep a chart, what days he was using more, times a day he was using more. And then the pharmacist took my notes and found a pattern. We contacted his doctor, who changed his medications, and wrote back thanking us for his help. But this chart did more than that. It got things rolling for him. His doctor wasn't getting any response from surgeons or specialists until she could prove he was working on baseline therapy for pain management. So thanks to this, he was finally ordered an MRI. And I began checking in with him and letting him tell me how things were going. He started out depressed and frustrated, slightly helpless from the stigma and the way people in medicine viewed him. His stories always seemed wild, with scary characters, people stealing from him and taking what little possessions he had, roommates who were offering street drugs to ease his pains, and how hard it was for him to say no. He had been stabbed, and oh, When in prison, he had developed a heroin addiction. It's that heroin addiction in prison that was making it hard for him to get a specialist. Wow. Here's the reason why the doctors are weary. I didn't really get it together until I heard that part. And it suddenly was reason that I was weary. But it didn't change that his spinal issues weren't real. These were real. Everything I reported back to his doctor helped her lobby to find a specialist who was willing to look beyond his past issues, to provide him with pain management, and to get him a surgery. So that MRI came back and it showed massive cartilage damage and dangerous impairments to his lumbar, and he should have had the surgery maybe 2 years prior to this. But it was a great stepping stone, and it was successful for him. In following up with the pharmacy, it took him from 7-day fills to 14-day fills, changes to his medications from hydromorphone to codeine, Tylenol to gabapentin, and gabapentin to duloxetine. From the MRI, he got a surgery, which I also helped him find a good social worker and a hospital advocate, and they helped him find an affordable physio program. The physiotherapist helped him find a job. So after his surgery, he was in less pain, and when the doctors approved it, he was able to start working, and this helped him find his own place and move away. His new life was going great, except for his new pharmacy. So he went to the new pharmacy to get his next 2-week fill on time, and the only thing the other pharmacy did was pull out a form and ask him a series after series of questions. 2 weeks later, he took 3 buses just to come back to our pharmacy. And he was telling me his new pharmacy made him feel like an inmate again, or like a robot. They were asking these innate questions. He was certain I was asking the same questions, but he appreciated that we showed kindness. As a pharmacy team, we were impressed with how much he improved over those next few years, but we always have to keep up with him, because life and humans will always have backslides, ups and downs, and in his own words, he'd rather tell me the truth about his pain management, even if it will hurt him to give his truth out loud, than know that we're worried about him. And he goes, I know you and the pharmacist will tell my doctor, but he knows we won't shame him for it, and he'd rather have us chit-chat, talk to him like he's human, than ask him a charitable question. Because after all, it takes courage to be vulnerable, and at our pharmacy, we will always value their truth. Are you guys still with me? I hope so. My last one's a bit hard. It's not a success story. It's not a success story. My final patient is LM. LM is a patient that is the hardest to talk about because not every person with OUD is on a path to success. Women on the streets are often taken advantage of, and I know that she represents a group of women who stay in abusive situations because of the economics. Hers starts with her abusive husband, who made a lot of money, and this is what kept her in a situation longer than she should have been. But when she left him, she had nothing. So she turned to working on the streets, trafficking her body, which often goes hand in hand with using drugs to get by. She was at the mercy of men. Trafficking is a heartbreaking subject, and when someone gets free, they will never emotionally be free. She currently lives in a housing project for women who have escaped human trafficking, and the house honors a concept of harm reduction. So that means that they are allowed to use within the house and within limits. But she was in a program, so she was not to use. So it kind of became difficult to share a room with someone who was openly using when you're trying not to. Her ups and downs are some of the hardest I have ever seen. In the summer, She reported going to her program daily. She came to the pharmacy daily for methadone. She was volunteering in a community garden so she could provide fresh vegetables for her whole house because fresh food was rare. And then it was strange. One day she just disappeared. I worried. It really shouldn't be my business to worry, but I worried for 3 weeks, over and over. What happened? Where did she go? We knew she wasn't going to another pharmacy because her doctors kept sending us notes that she had missed her appointments and was about to lose her spot in the program. Her house was sending us notes that stated after 14 days, her room would be given to someone who was waiting and in high need. What do you do? As a technician, my only job is supposed to be best practice medical history, filling medications, and that's it, and reporting back to the pharmacist, who then gives a daily witness dose. But here I was, as a human and a feminist, worried. Maybe it's okay to worry. Maybe it was important for me to worry. Finally, the police came to the store. Her family was doing a welfare check. We still had not seen her. But if we do, can we please call? She eventually reappeared in the fall. She was being manipulated by a man who made her return to trafficking. He was trading her for money and for food. He maintained complete control over her. And it was frightening, and she would come in and talk to me about him. And I could not comprehend what living like that meant. It was such a situation. When you come out of an abusive relationship and already have a history of human trafficking, it was very likely that another man will do the same to them. Her story, her truth, became very painful to listen to. She was head over heels in love with this disgusting man who had full control over her. And there was nothing I could say or do. That's not my role. They had been staying on the streets. The police had found her and intervened. Maybe she even spent some time incarcerated. She went back into her program, but the street drugs she had used in those few weeks were enough to damage her heart, and now she could no longer do methadone or Suboxone. Her only option was Cadian. It would be too risky on her heart to do anything else. We have to understand our limits in the scope of practice. I can't save anyone from themselves. I can't cure opioid use disorder, but I can be there every day as a place for someone to come and be a person who listens. I'm not able to keep things secret, and they know that. I have to pass on every detail of street drug use, and it's the pharmacists and the doctors that make the decisions if the patient gets their daily witness or need changes to their program. It's going to be the opioid dependency program doctors that make all the final decisions. But my job is to listen and report. And it can be painful. I take away these stories and now I have to carry them. And sometimes it gives me secondhand PTSD. For those going through opioid use disorder, life can be a struggle. And at the end of the day, I want you to remember that this crisis, as they call it, has a human face. They might be a statistic on a piece of paper, but first and foremost, they are a person. I want you to take away from this presentation that working with patients with opioid use disorder is going to be a struggle. Some might be mean and nasty, and it will be tough to hear their struggle. I want you to reconsider your forms and your checkboxes. I want you to let them tell their stories, to push past the stigmas, and to remember we are all human beings with a right to dignity. And then this is my sources, but I thought I'd also give you some updates about myself, where I'm working now, and some of the patients. When I wrote this, I was working at Luke's, and Luke's was an independent, and based on its location, was doing outreach. When I worked there, it meant finding people food, it meant finding people social workers, it meant finding people housing, it meant contacting police. It was a very difficult and rough place to be. I found myself on my birthday injecting naloxone because I found, well, I didn't find, but another individual found someone in our parking lot. And then when I got there, he drove away because he's like, oh, good, you can deal with this. And I didn't even remember it was my birthday or that I was going to go to birthday dinner. I just jumped into action and called EMS and started my injection of naloxone and all this stuff. And then I was late for dinner and didn't know where I was or up from down that day. And it was those kinds of things that were taking a toll on me. So I joined a new program. It's at the Alex, and the Alex is an amazing program where everything is in-house. We have a big kitchen to feed people. We have 3 or 4 different clinics, one for youth, one for the community, and one for pathways to housing. We have outreach buses, outreach nurses, we have social workers and doctors all under one roof. So I still get to do this outreach level of pharmacy, but in a much more supported way. So that's my presentation. I hope that helped. Can you see me, hear me still? Yes?
Yes, we're still here, Carrie Ann. Thanks so much for that presentation. If it's okay with you, I will open it up to questions now.
Okay.
Does anyone from St. John have any questions or comments for Carrie Ann? So no questions here. What about in Moncton?
Yeah, Heather, this is Doug Doucette. Can you hear me?
Yep.
Okay. Carrie Ann, thank you so much for sharing. I can certainly see why our staff who attended the CAP session last year put your name forward to come and speak with us today. Incredible experience that you've shared from your practice with us. Very personal, very passionate and inspiring. And I'm happy to hear that you found another place to land and continue your practice. I can only imagine how challenging it was doing the work that you were doing at Luke's and some of the other work you've done. In terms of the time that you've been a pharmacy technician, was there something along the way that you found helped prepare you to take on these types of challenging and innovative roles?
The first year I struggled. I struggled so hard, and I was like, this is a scary place to work. My family wanted me to quit. Like, I was drowning, and I didn't feel like there was support. I went to a conference, and I met a technician who worked in Vancouver. She worked in the deepest, darkest pits of that, and she got up and shared about harm reduction and shared about being more vulnerable and how to do that and how to work towards that. And because she shared her story, it was so inspiring. I went home and I started doing more research. I started doing more research on harm reduction, housing projects, how mental health and addictions work. And I started gearing everything I was doing to the situations I was seeing every day. I started researching where I can find food for patients, all the different types of food banks we have in the city. And I started looking at different mental health projects, how to get a person a hospital advocate. Like, it just drove me to do better because I wasn't rising to the occasion before. I was just drowning. And so she inspired me. And the reason I share my story now is because there might be somebody out there who needs the same inspiration, needs to know, like, hey, you're not alone in this practice, and that if we work collaboratively, we can help people. We can lift people up and we can lift each other up. I hope that answers your question. Yes? It
does. Thanks. And I was really, really happy to hear you say, even on the toughest days, the best thing you can do when someone's cranky or nasty or not sure what to do is just to sit and listen to them. So that's great advice, regardless of what our name badge says we do day to day. Thank you.
Thank you.
Thanks, Doug. Any other questions from any of the other satellite sites signed on? I did have one question for you, Carrie. I know you touched on this in the presentation about how people do seem to get defensive with the formal forms and check boxes and doing a med history. I know in hospitals here, a lot of our pharmacists and pharmacy technicians and assistants do the best possible medication histories. And that's often a question we are asking people coming into hospital, is whether they use illicit drugs or tobacco products at home. So do you have any tips on how to approach that where we don't come off offending someone? I know it's a difficult subject sometimes to bring up.
The best way is to be open and remind them that, like, it's not against them. There's no shame there. It is hard. Like, the first few times I brought out a form, like, I actually had someone spit on me and walk away and call me a nincompoop, which was offensive to me. I was like, whoa. But sometimes it will take more than one try to get them to talk about illicit drug use. I like to pair it up with normal things, like how much coffee they're drinking, how many vitamins they're taking. So, like, if I put it in a section where it's just as normal as coffee drinking, they start to kind of open up. Like, a person who is drinking will tell you, like, exactly how many beers. Like, I drink 24 beers. I drink two things of vodka at 8 ounces at this amount of time. Like, if you start to make it as normal as asking how often they take their bisoprolol, it starts to come out. But it was a struggle. Like, it wasn't easy. Sometimes people trust you and sometimes they don't. I like to tell them that it still becomes an autonomy for them. Like, I don't automatically have to tell their doctor. So if they tell me about their illicit drug use, I encourage them to tell their doctor themselves, and I ask them if it's okay before I state it. Like, it's a rocky ethical place sometimes they'll put me in. So if it's something that's not harming others and it's only something they're using and doing, then I do. I leave it up to them. I hope that answers the question. Yes?
Yes, that was great. Thanks, Carrie Ann. So last call for questions. Okay, well, that wraps it up for today. So once again, thank you so much, Carrie Ann, for sharing your experience and your story. Really appreciate it.
Thank you for having me, and thank you for the opportunity.
Thank you. So we'll see everybody back in a few weeks for Journal Club. Enjoy the rest of your week.
Thank you.